First of all, thank you everyone, or all our attendees joining in tonight. We really appreciate your time in such a busy time of year. Tonight, we're going to be going over the updated flu vaccine products and who they should be used for, the updated vaccine recommendations for this year for both flu and COVID-19. We'll go over Paxlovid and adult immunizations as well. So it's a bit of a packed session. We'll try to get through it all within the next 50 minutes or so we can leave some time for Q&A. As a reminder, our review will be national in scope, so we won't get into the minute details of each flu program, but the goal of the evening is to provide background on the available vaccines that you should be aware of this season, and also to review Paxlovid and the latest updates for adult immunizations.
Thank you, Molly. First, let's start with a few introductions. Hopefully, most of you have run into Molly and myself before on these presentations. However, as a reminder, myself, James Morrison, I'm a pharmacist here in Ontario, and we have Dr. Molly Yang, and she is a pharmacist as well, a little bit more recently qualified than myself, and we both serve as directors at Whole Health, myself primarily in pharmacy operations, and Molly oversees our professional programs in innovation that we offer here at Whole Health. We're pleased to be joined tonight by a pharmacy student, soon to be pharmacist, Run Yang, who is a U of T student in his 4th year.
Nice to meet everyone.
Happy to have you on here with us tonight, Run Yang. Before we get into it, a quick disclosure that Whole Health as a banner, we do collaborate with a variety of organizations, including companies whose products will be discussed in this presentation. For this session particularly, we have not received specific funding.
Yeah, and Molly, I forgot to mention that we are recording this session, so it will be available on our Facebook and on our YouTube, and we will send it out to everyone who registered as well. And as well as a copy of the slides, we'll distribute to all the registrants, so you'll have a really handy resource to look back to through this flu season. We'll be monitoring for questions. As there are, several sections to this presentation, we'll try and manage any questions at the pause between each section. So please type them into the Q&A function as we go, and we'll try and get to as many as we can.
Thanks, James. So as a quick run through of the agenda, first of all, we'll go through influenza and the recommendations for the flu season, followed by COVID-19 vaccines and Paxlovid, and then updates to older adult immunizations, finally rounding out with some operational tips and reminders for how to incorporate some of the recommendations into your workflow. So we'll start out with an overview of influenza. We put the slide in here to kind of look ahead at the season we have ahead of us. If we start on the right side of the slide, this is data from the season in Australia. So the 2022 flu season in Australia, usually Australia gets their season before us in the summertime months. They saw a drastic increase in laboratory confirmed influenza cases compared to the cases of the last 5 years. So during COVID and before COVID, this year they saw more cases than the last 5 years. So very significant. Looking on the left side of the slide, we've summarized a couple of statistics from Canada. So in the last flu season, only about 39% of Canadian adults received their flu shot. So it wasn't too high of an uptake, unfortunately. However, most of those adults did get vaccinated at the pharmacy. Looking ahead to this year, only about half of Canadians say that they will get the flu shot this year. So that data in combination with what we see in Australia is a little bit alarming. So the overall message is that we have a role as community pharmacists as we're slowly becoming these community hubs for vaccines within our communities to promote influenza vaccine uptake.
So Molly, that slide's really telling, with pharmacists now managing more than half of the flu shots every year, or pharmacy teams, I should say, because we know there's technicians in certain jurisdictions playing an important role here. But this gap with only half of Canadians interested in getting a flu shot? Like, how do we suggest pharmacists do what they can to push that number up?
Yeah, it's a great point and stuff that we'll talk about later on in the presentation too. But a lot of it, there's data to show that when pharmacists make a strong recommendations to patients, then it's taken seriously. Patients will take our recommendations, especially for patients who, may be at higher risk. We can really identify personal reasons as to why they would want to get vaccinated with flu vaccines and other vaccines. Really good point to make. In this next slide, just a few details about the flu. We know there's two main types that we focus on for influenza, influenza A and B. And A causes the more common types of flu, and it causes the pandemic, so H1N1, H3N2, and also accounts for the majority of cases, with particularly high burden in older adults. We know that influenza is very significant. Influenza is a top 10 cause of death in Canada. It causes direct effects on the lungs, but also indirect effects on other organs across the body, can be very dangerous, triggering myocardial infarctions, exacerbating various chronic health conditions. So it's important to recommend that these patients get vaccinated. And to answer the question, why do we need an annual vaccine? Because the fact is that the flu virus is highly immunogenic. So even more so than COVID-19, there's global surveillance of influenza every year where the World Health Organization identifies the strains that they recommend to be included within each year's flu vaccines.
Okay, thank you, Molly. So I'm going to talk a little bit about who is at risk for the influenza virus. So, there are high-risk groups, and there are groups that can transmit influenza to these high-risk groups, right? So the groups are listed here, and we just want to really be careful because we are, we all work in the pharmacy, and we are actually a point of contact and one of the groups that can transmit the influenza. So older adults are, most affected because they are more susceptible to infections due to a weakening immune system. And unfortunately, they contribute to 70% of flu hospitalizations and 91% of flu deaths.
Yeah, really good point, Runyang. And here, usually in most of our flu programs across Canada, we will try to prioritize some of these at-risk patients first, making sure that they're protected in the beginning of the flu season.
And here, just wanted to, outline the symptoms for some of the common respiratory diseases out there. So these symptoms are all very non-specific. And so it's ideal to actually get vaccinated against everything that, you can. That way, we can sort of, just prevent having symptoms and going to the doctor and going through the process of, figuring out which disease you have. So there's COVID-19, there's the common cold, there's flu, and there's pneumonia as well. So just wanted to outline that, yeah.
Yeah, we won't go through each one of these, but it's just an overall review to show how it can be difficult to see what's what. So we do want to make sure our patients are fully protected.
And just wanted to, so the next section here is flu season for this year, 2022 to 2023. Just want to begin by talking about the available flu vaccines in Canada. So as many of you have probably already know that there are two main categories of flu vaccines, the quadrivalent and the trivalent. So quadrivalent covers two A influenza strains and two B influenza strains. So that means there's more protection here, while trivalent covers two A strains and only one B strain. So the A strain is typically associated with worse disease, especially in the senior population. If you look at the vaccines here under quadrivalent, there are 5 different kinds of vaccines. There's the inactivated vaccine. It comes as a standard dose and high dose. These have been around for many years now. Fluclovax is a relatively new vaccine. It is an inactivated vaccine that is created in cell cultures rather than egg cultures. So what this means is that this vaccine may actually have a closer antigenic match to the circulating strains of the virus in mammalian cells. And it's also important that when it's not produced in egg cell culture, we can avoid egg-adapted mutations. The live attenuated vaccines here is usually given from the nose, so intranasally, and it's typically indicated for people who are aged 2 to 17, even though people older can get it as well, the adults. But in Canada, it's generally recommended and given to ages 2 to 17. The recombinant vaccine is new this year, and the one that's on the Canadian market is called Supemtec. Molly will talk more about that in a little bit. It is not covered by any provincial and territorial government, but it does contain antigens that are an exact match to the influenza strain. So this gives us more protection as well. And lastly, as for the trivalent, the only one that is in Canada this year is the Fluad, and it contains an adjuvant which boosts immunity. So on the right-hand side here, we also included some product information just for your reference. So feel free to come back to this slide in the future if you or your patient have any questions about, what's inside the vaccine, what kind of format it's in, if it's, pre-filled doses or multi-dose vials and things like that.
All right, thanks so much, Renyang. As Renyang mentioned, Supemtec is new this year. It uses recombinant technology. So to make a vaccine that contains the exact match of the hemagglutinin protein antigens of the flu strains identified by the World Health Organization. So the benefits of using this technology include no exposure to egg or other cell adaptations, making it a better match and potentially more immunogenic as well. There's also no antibiotics in it, no preservatives, latex, or gelatin, and it contains 3 times more antigen than a standard dose. So it is indicated for patients, adults 18 plus, and it's applied in a single dose pre-filled syringe. And again, one dose contains 45 micrograms of hemagglutinin of each strain, whereas the standard dose only has 15 micrograms of each strain, and high dose has 60 micrograms. So it's in between the contents of the standard dose and the high dose. In terms of immunogenicity or efficacy, there was a study in the New England Journal of Medicine which found a 30% lower rate of influenza in patients who had received Supemtec versus the standard dose quadrivalent vaccine. And this was in patients who were 50 plus. So in total, Supemtec may be a good choice for adults who are 50 to 64 or potentially 18 plus with comorbidities, because this age group is not yet eligible for the high dose flu vaccine, which we know has a higher concentration of the hemagglutinin per dose. One thing to note, however, is the fact that it's Schedule 1 because it's a new vaccine. It's not included in any of the provincial programs, so you do need a prescription, but you can bill this as a regular prescription.
Great. So here I just want to provide a little summary on what we've discussed so far. So there was a lot of information in the last couple of slides. Here, just mainly want to talk about, the differences between the different types of vaccines. So it's important to, remember that FluMist, the intranasal vaccine, is administered as 0.1 milliliter per nostril. So it's a 0.2 mil vaccine in total. And the volume for the Fluzone high dose is actually 0.7 milliliters, so not 0.5. It is a little bit more. Also, the live attenuated has more contraindications. So always screen your patients and, look at the criteria that's outlined by your province or territory to see if your patient is eligible. For example, it is contraindicated in pregnancy. So that's something that we should always consider before giving this out. The Fluclovax has no egg exposure, and it provides better match to mammalian cells. Fluad is the only one that's adjuvanted this year, and the recombinant vaccine contains actually 3 times more antigen than the standard dose, but it still has less antigen than the high dose, so somewhere in between. And this is more, I guess, for operations and practical aspects, where we want to just show everybody what is available in each province and territory. So after doing a little bit of digging, we see that the quadrivalent vaccine is actually publicly funded for all eligible patients. And sorry, that's the standard dose. So it's publicly funded for all patients in every province and territory. But the high dose quadrivalents and the adjuvant or trivalents, which are both for seniors 65 years and over, they're not always necessarily funded. So provinces like British Columbia, Quebec, Nova Scotia, and Nunavut only fund the high dose for elderly patients who are at increased high risk of getting the flu. And these provinces have a red check mark. So the blue check mark here on this slide means that the public funding is available for all seniors, regardless of risk level. And lastly, the cell cultured vaccine and recombinant inactivated vaccines are not publicly funded in any provincial and territory formularies, and that's why they don't have any check marks. And here, I thought it would be helpful for everybody to include a slide on the start dates of the influenza vaccine program. So some of them are rough estimate. Some other provinces have an exact date, but I mean, pretty much they all start sometime this month. I know Newfoundland is starting their vaccination program on Monday, so the coming Monday, for example. So that's something for you guys to consider. And also, if you click on the little yellow circle here on the map, you can actually find a link to your provincial and territorial guidelines for the influenza. So make sure to check it out if you have any questions.
Yeah, something to look back on.
Yeah.
So Molly, there's a couple good questions and Runyang. So the first one is, are there any provinces covering high dose flu for the immune compromised this year? Presumably they're asking about under 65. And I would add to that question, who under 65 might be a good candidate for that, if anyone, Molly, and what would be the course maybe through private funding for that?
Yeah, good question. So as we see on the summary slide that Runyon presented, there is coverage for age 65 plus for the high dose quadrivalent. I'm not aware of anything under 65 for the high dose quadrivalent, but for those patients, I would recommend an option like the recombinant vaccine Supemtech that we talked about, which has the 45 micrograms of antigen per strain as a good option for those patients, as it was found to reduce the rate of influenza, especially in the age 50 plus group, but it can be used 18 plus. Do you have anything else to add, Runyang?
Nope, that's basically what I have as well.
And then the other question is regarding private insurance, presumably for Supemtech. Is there any coverage that we're aware of?
It's tough to answer because private insurance can vary greatly by plan. I have heard of several plans that do cover Supemtech, so they'll have to work with the patient to figure it out within their specific plan.
Okay, yeah. So on this slide, I just want to quickly go over some of the new things that are happening in some provinces for immunizations for pharmacists. So the great news about this year's flu program is that the high dose quadrivalent vaccine is now publicly funded for all seniors 65 years and older in British Columbia, Manitoba, and Saskatchewan. So it's no longer restricted by, only to people who are in long-term care homes or at high risk. Additionally, Manitoba now allows pharmacists to give the COVID-19 and flu vaccine to individuals 2 years of age and older. And Nova Scotia now allows pharmacists to give COVID-19 and flu vaccines to individuals 6 months to 2 years of age. In all other provinces, the minimum age is still 2 years and up.
Okay, so we'll jump into some clinical tips, and these issues and questions might come up a lot in your practice during the flu season. One of the main questions that we get is, with all of these flu vaccine options, which one should I get in the pharmacy today? Ultimately, the message from NACI and from all the provinces is, of course, the best vaccine is the one you get today. We want to make sure that patients are protected as early as possible in the flu season with whatever option that they're eligible to get. However, if you are in a province where there is provincial funding for multiple products, or the patient is willing to pay for certain products, there may be some considerations that you'll make when it comes to choosing a vaccine on an individual level basis. So we can summarize that on this slide. So taking a look at the options for 6 months to under 2 years, the product is the standard dose quadrivalent vaccine, so just the standard vaccine for ages 2 to 17 years old. It's also the standard dose quadrivalent, or if you have a patient, especially with needle phobia or an aversion to getting vaccines, you may want to consider live attenuated quadrivalent vaccine. It is covered in certain provinces, but if it's not, the patient may want to pay for it. For adults 18 to 64, the option is also standard dose quadrivalent, or again, as we mentioned, if there are comorbidities such as chronic kidney disease, cardiovascular disease, etc., or for patients 50 to 64, then that additional antigen in there, and the fact that it's recombinant, that it's the exact match to the current identified vaccine strains, that might make it a good option for certain patients if they would want to pay. So because it's not publicly funded, that's a decision you'll have to make with the patient. In the 65 plus age group, depending on what's publicly funded, you might have high dose quadrivalent, you might have adjuvanted trivalent, and you also have standard dose quadrivalent. So the preference would be to give high dose quadrivalent, followed by adjuvanted trivalent if it's publicly funded within your province. If those aren't available, there's also recombinant quadrivalent, which can be used. And if none of those options are available, the standard dose quadrivalent is also still a good option, as long as they're still getting that protection from the flu vaccine. I've just put in a note here on the right-hand side that there's a lack of studies to directly compare the high dose quadrivalent, which is this option here for 65 plus, to other vaccines, although NACI confirms that high dose should be used over standard dose on an individual level, although there's insufficient evidence to really make a distinction or a comparative recommendation between the trivalent adjuvanted or the high dose quadrivalent. Because of the data that we have, where we know there is a good increase in efficacy compared to standard dose with the high dose quadrivalent, I would prioritize that first. But overall, the message is not to delay vaccination. And we just added a note here at the bottom that for patients aged 2 to 9, if this is their first flu shot, there needs to be a second dose at an interval of 4 weeks.
So Molly, there's some questions that relate specifically to this slide. Why is the adjuvanted trivalent only recommended to 65 plus? Is that like an approved indication, or is it more like a funding concern?
Yeah, so good question. It was based more on a funding decision. If we see on here the adjuvanted, also Fluad, it's indicated for ages 65 plus, so it's a bit of both. In reality, if we are taking a look at if high dose is not available, sorry, it's a couple of slides back. If high dose is not available because of some of the evidence we have with the recombinant quadrivalent, I would feel very comfortable giving that one over the adjuvanted trivalent. But based on NACI, all of these options are good options. It's hard to make a comparison because of the lack of data here. But here's what we highlighted.
couple other questions. So one of the questions is 2 years and up for both influenza and COVID. And there might be provincial nuances to answering that question. But in Ontario, pharmacy professionals that are giving vaccines can do COVID for 6 months and up, but flu is just 2 and up. And that might vary province to province. I don't know if we have a summary comparing both, do we, Molly?
We don't have a summary exactly for that, but for example, Nova Scotia is 6 months for both COVID and flu. But if summary works better, maybe we can try to provide that later on to make it easier to understand.
I think that you do have links to all the provincial guidelines that you're going to be sharing anyways, Wanyang, so that should probably answer that question for anyone who's interested. And there's a question here about funding, specifically for Ontario, for patients who need that second flu shot, the ages 2 to 9, if it's their first flu vaccine, is that funded? And the answer is yes, like you would be able to bill a second flu shot for that patient if it was their very first flu vaccine and they needed that booster. Another question there about that first flu shot scenario, Molly, if the patient turned 9 and this is their first flu vaccination, do they still need a series of 2 flu vaccines or 1?
Yes, I would give the second dose 4 weeks later. Okay, great questions. Good. I see the next question coming in, and it's a great question, very timely because it's the next slide on our presentation. So concurrent administration of vaccines. The latest NACI update is that for ages 5 and up, all seasonal vaccines, including the live vaccines, so FluMist, can be given at the same time or any time before or after other vaccines including COVID-19 for ages 6 months to 5 years. So under 5 years, it is still recommended to space COVID-19 vaccines by at least 14 days with other vaccines. And just as a reminder that it's preferred to give vaccines on the same day so we don't lose the patient. We can get them vaccinated and protected all in the same visit, but definitely a reminder to use different needles and syringes when giving these vaccines and to separate the vaccines by at least 1 inch if they're on the same arm or to use the opposite arm. So these next couple of slides we've just put in here. I won't go over injection technique, but we put this slide in here for you to refer to if you'd like. And we've put this anaphylaxis guidance in here as well on observation times, how to identify anaphylaxis, and epinephrine dosing by weight, which you can take a look at after the presentation.
Okay, great. Thanks, Molly. So here I'm going to talk about the bivalent COVID-19 vaccine. This is pretty exciting because we just actually got the new Pfizer approved recently. So onto the next slide. I'm just going to go over, very quick overview on what Omicron is. So as we all know, majority of COVID cases, today are caused by the Omicron variants, and this variant is actually the most different strain from the original strain. And it's expected that future lineages will come from the Omicron variant. So as a result of that, Health Canada recently approved the Pfizer bivalent vaccine as well. The Moderna one was approved in the beginning of around September. So now we have 2 different kinds of Omicron containing vaccines. The Pfizer vaccine will be coming to each province and territory soon. I think in Ontario, we already got some in the pharmacies, but I think the other provinces probably are still waiting on it a little bit. So it's important to know that the Moderna and Pfizer bivalent actually don't cover the exact same strains, as Moderna covers the original strain and the Omicron BA.1 strain, whereas Pfizer covers the original strain and the Omicron BA.4 and BA.5 strain. There is unlikely to be much clinical difference between the Pfizer and Moderna boosters, even though they cover different strains, kind of. Any advantage that Pfizer offers with a BA4 and 5 target, Moderna may make up for that with a higher dose. In studies, it was found to be, immunogenic against BA4 and BA5 for Moderna. So the most recent NACI recommendation says that everyone 12 years and older should get the fall booster dose. But Pfizer is indicated for ages 12 to 17, whereas Moderna is not. This may vary by province and clinical discretion, mostly because Moderna doesn't have any safety evidence yet for individuals that are younger than 18 years old. And, even though the bivalent booster is highly recommended, individuals 12 years of age and older who are not able to, or, were unwilling to receive a bivalent Omicron containing vaccine can still receive just the original vaccine. And on the bottom here, just some things to consider. And so if someone was recently boosted with an original vaccine, just reassure them that, that's totally okay. The original vaccine still offers a good boost to immunity. They can get a bivalent when they're eligible for their next dose. And the risk of myocarditis appear to be highest with the primary series and not as much with the boosters. So that's also something to reassure your patients with.
Yeah, good points, Runyang. I would just mention here that sometimes we hear patients want to get, an original mRNA vaccine or some of the other options like Novavax or another vaccine instead of bivalent. I would just make sure that, we counsel the patient and that they know that this bivalent vaccine is different than the other vaccines. It actually contains the Omicron so that they can make an informed decision on which vaccine to receive.
Yeah, 100%. Yeah. I also included a little summary table for everybody to see. So this is something that the whole health team created. It's the Moderna product comparison. So right now there are 3 products out there, and just showing everybody, what the difference in color might be, different ways to store them. Just maybe keep in mind that this chart here is made using the product monograph. So some of the criteria might differ depending on the province and territory, because sometimes they have their own little differences.
Yeah, with eligibility or dose intervals and things like that. Good point. Yeah.
And here is just products for Pfizer. So there is more Pfizer products. And so one thing that I really want to tell everybody is that the bivalent does not need to be mixed. So that's something just to be aware of. And this table is from the Pfizer website. You can click on the link on the bottom to find more information on expiry and other product information. And lastly, for bivalent vaccine, here is a map and links for you to check on for your provincial and territorial guidelines. Okay. I think we have some questions. Yeah.
Thanks, Runyang. So before we shift gears completely, let's address some of these questions. So I'm not sure, Molly, if you know the answer or Runyang to that first question. If there's an adverse reaction after getting both flu and COVID shot simultaneously, do you submit adverse event forms for each vaccine?
Good question. I'm actually not sure of this. What do you think, James?
So I think that you would, if you can't determine which vaccine, like there's room to write in information on those reporting forms. Mm-hmm. So you could describe the situation, and then when you submit it, Health Canada would follow up. So okay. That's what I would suggest. Really good question that we get a lot. Can a non-vaccinated patient, so if we happen to find somebody who's raised their hand, now they want to get their COVID vaccine after a couple of years, what do you start them with? Do you give them bivalent to start?
Great question. Do you want to take that, Runyang?
Yeah, so the bivalent vaccines are strictly booster doses. So NACI said that they are not supposed to be given as primary series, so they cannot be given as your first or second dose. Now, in terms of if somebody got it like in the beginning of 2020, but hasn't gotten a booster at all since, since then, I would say there's nothing that said that, once a certain amount of time has passed and you have to go back to the primary original vaccines. It's more so that just the fact that you've already completed your primary series, and then you're considered to be on your boosters, and the bivalent would be appropriate.
Couple other really good questions here. So how high is the myocarditis risk? And is there an age group where it's more likely? For example, the original Moderna series might have been more prevalent for those males above 40 for myocarditis versus Pfizer vaccine.
So I don't know if Molly, do you want to take this, or?
Good question, Bryony, and I can get back to you, Bryony. I don't have the exact numbers right in front of me, but we do know with the bivalent vaccines, there seems to be less of a risk compared to that initial series.
Yeah,
especially, go ahead.
Oh yeah, and some sources have said that the fact that Moderna is indicated for 18 years and older, it's good because myocarditis have also been found in young adult populations as well. So the fact that 12 to 17 is Pfizer can hopefully, maybe if there's any risk with Moderna, that will sort of be taken care of. But from what we know so far, there's definitely less risk with the bivalent boosters compared to the originals. Yeah.
So this next question, I'm not exactly sure what's being asked, so I'll ask it a couple ways. So what if this person's already had COVID before? Can they skip the primary series? And I'll also ask, what if this person's had COVID and they've already completed a primary series? How long do they wait to be boosted? So there's a couple questions for you.
So, okay, yeah, sorry.
Go ahead, take it. Okay.
I can definitely answer the second question, which is if they already got their primary series and they got COVID, they can definitely still get boosted, but you would sort of treat the infection as a booster dose. So for a booster dose, you should wait 6 months, but you can wait for only 3 months if you think that you're at higher risk. And that would go for the same for an infection. So you would also have to wait for a minimum. You should wait for a minimum of 3 months. 6 months is better.
Yeah. So if they have never gotten the COVID-19 vaccines and they have been infected with COVID before, you would still recommend the COVID-19 vaccine after a period, which Ranyang said before. So after, it's expert opinion and based on, what we know about the immune system, waiting that 3 to 6 months, but technically you're not limited to the 3 to 6 months if you can give it, or if the patient does want it a little bit earlier, it is a suggestion to wait that amount of time. But if they have not received COVID vaccines, you would want them to receive that COVID vaccine because the immunogenicity with the vaccine is better.
So the other question here is on vaccines. So we'll take this last one before the next section. And we've actually already answered this question once, but regarding Ontario, COVID vaccines can be given to 6 months and up. Is it the same for flu? Flu for pharmacy professionals is still 2 years and over in Ontario. So there's that difference. So COVID shots, we can do 6 months and up, and flu is 2 and up.
Thanks, James. Okay. And I'm also going to quickly talk about treatments for COVID. So I'm going to mostly focus on Paxlovid, but I'm also going to talk about the other treatments. So Paxlovid is an antiviral medication indicated for COVID-19, and it is taken twice daily, and patients have to take it for 5 consecutive days. So each dose contains 2 tablets of nirmatrelvir and 1 tablet of ritonavir. So we've summarized some eligibility criteria here, just next to the picture of the Paxlovid. So note that there's also a list of more specific individual criteria that would be listed on the health service websites for your province and territory. It's a very lengthy list, so I didn't include it here, but it should be very easy to find online. So there's just things that define, what is considered high risk, and what if you're not vaccinated, or et cetera. So that's something to make sure to refer to before you make that clinical judgment. There's two other options for COVID-19. One is remdesivir, that's also an antiviral. So this one is not very relevant to the community pharmacy setting because it is administered intravenously, usually in the hospital. But the second one here is Evusheld, which is actually an antibody. So this one is not antiviral, and it is not used to treat COVID, but rather given to prevent COVID-19 infection. But very important to note that even though it's given to prevent COVID-19, it should never replace the actual vaccination. So this is usually given to people who are immunocompromised or people who just are at higher risk of getting COVID. So pharmacists can dispense Evusheld, which is why I want to talk about it. Again, it requires a prescription and it requires a thorough clinical review on the patient's condition before it can be dispensed. It is a intramuscular injection though, and based on the monograph, it's recommended to be given to the gluteal parts instead of the arms. So a little bit more on Paxlovid. So here we talked about the dosing. Very important to keep in mind that now there's actually two different types of Paxlovid in the market, so two different DINs. The new DIN is specifically for renally impaired individuals, and that dosing information is in the orange. The green is the original regular dose Paxlovid. So when people have impaired renal function, you really want to consider the EGFR, their EGFR, and using the scale provided on the slide to determine what dosing is the most appropriate for your patients. And we also talk a little bit about, what happens if you miss a dose, the common side effects of Paxlovid, and drug interactions, which is quite numerous because of the CYP3A4 metabolic nature. And on the bottom here, so also there's a little link for Liverpool COVID-19 interaction checker. If you're not sure if a drug interacts with Paxlovid, you can definitely use that link to help you determine any interactions. And lastly, this is the eligibility section for Paxlovid for the nation. So you can click on your province and territory for information.
I just would like to mention as well on this slide that we know across the country uptake for Paxlovid hasn't been that high. It has been pretty low. So just a reminder to promote awareness around Paxlovid, especially for access and, so patients can get it in a timely manner, especially for those high risk patients or eligible patients in your province. Older patients who haven't been immunized or who have chronic conditions, reminding them that there is an option if they do happen to get COVID-19, how they can access it and how quickly they need to act, right, within that 5-day window. You can use social media, flyers, or signage to make sure patients are aware that pharmacists are a resource for Paxlovid. And especially in provinces like Ontario, where we have the pharmaceutical opinion program, where there is remuneration for providing that recommendation to prescribers for patients who would be eligible for Paxlovid. So including those patients who would be at high risk for transitioning to more severe COVID.
So there are a couple questions here about treatments. Maybe Molly or your cat could address them. But the first question, can Evusheld be given to a patient with an active infection? If yes, how is that preventative?
Evusheld is indicated for preventative prophylaxis, so it's pre-exposure. If a patient currently has COVID-19, then it shouldn't be given to the patient. Maybe after they've recovered, and you can consider giving them Evusheld to prevent a future infection from occurring.
So the other question, I'm not sure if you've heard of this one, but a third dosing is also being prescribed for dialysis patients. Presumably they're talking about Paxlovid here, though uncommonly. Is that dose approved by any province so far?
I haven't heard of it, and even on drug product database, there's only 2 that's approved so far. Molly, what do you think?
Yeah, good question here. I haven't come across that. If somebody has, on the call here has any insight on that, please let us know, but we'll look into it and we'll get back to you on that.
Thank you.
And the other question is going back to vaccines again, but if you have a patient who's insisting on getting the original Pfizer or Moderna as their first or second booster, like what do you do in that situation? They had a family of 3 who wanted to get regular Pfizer as their second booster, despite the pharmacist making best efforts to convince them to take a bivalent vaccine.
Yeah, it's a tough situation, right? Because you know that you're making recommendations in the best interest of your patients, but obviously we have to respect patient autonomy. At the end of the day, if you provided them with the information to make that informed decision, then we do have to respect their decision.
Yeah, and just to add on to what Molly said, it's okay to give them the original series as boosters, even though it's not recommended anymore, simply because of the extra protection that bivalent vaccines can provide you with. But then again, even with the regular original vaccines, you can still get some pretty good protection. So it's better than nothing. Yeah.
So more questions pouring in here. So Linda's trying to assist with that question about modified dosing, saying that she's heard the Liverpool reference has guidance dosing for EGFRs less than 30.
Yeah, that's great to know. I think ultimately, if, for those patients, you would want to work collaboratively with the prescriber as well. So it wouldn't be a sole decision on the pharmacist part.
And the next question, Molly, you might address later on, but it's regarding Moderna and Shingrix. Do they need to be separated by 14 days because of the adjuvant?
Good question. So with adjuvanted vaccines, because we don't have too much evidence on, interactions between adjuvanted products being co-administered together, there isn't too much guidance on it. Expert opinion might say waiting, spacing it out within a day or not a day, a week or so. However, I know that many of our pharmacists have been giving Moderna and Shingrix together. And so, there might be an increase in the side effects, the local and systemic side effects when you do so. But it wouldn't be wrong to co-administer those vaccines.
Another question here, somebody who took Moderna bivalent, can they take the Pfizer bivalent after a specific time?
Good question. So I think, when those recommendations come out for the next booster after the bivalent, we'll likely see that it can be either one, either Moderna or Pfizer is what I'm expecting. So for their next booster, it'll just be whatever's available.
Yeah, and what we've been seeing is guidelines evolving to be, if it's been 6 months, you can boost them with an appropriate booster.
Yeah.
If the patient never had COVID before and insists on getting Pfizer bivalent as a primary vaccine, should they respect the patient's decision?
Yeah, good question too. However, the Pfizer or Moderna bivalent products are only indicated as boosters, so we cannot give them that vaccine without having already a primary series.
Yeah. So Next question is, which COVID vaccines specifically are adjuvanted?
I know a couple of them are. Runyan, do you have that right in front of you?
I don't have it right in front of me, but
So I know off the top of my head, Medicago and Novavax are definitely adjuvanted.
but I think the question is asking what COVID vaccines are adjuvanted.
Yep. So Medicago and Novavax COVID vaccines.
So the majority of them are not. So the ones that we're using in most of our provincial programs are mRNA vaccines primarily, which are not adjuvanted. The concern is when you might be administering another vaccine alongside a COVID shot.
Yeah.
Okay.
So let's hold the rest of the questions and keep moving because we're coming up on.
We still have a couple of slides. We're almost done, guys. So we'll go through these next couple of slides and then go over any other questions that you have. I just want to take the next couple of minutes to quickly go over some very key updates with adult immunizations that you guys will come across this season. So the first thing we'll go over is Prevnar 20, which I'm sure most of you have noticed has come into the market. It was new this summer. It's a conjugate vaccine like its predecessor, Prevnar 13. And like Prevnar 13, it contains those 13 strains of pneumococcal pneumonia that it protects against, plus an additional 7 strains. It is indicated for ages 18 and up. And because it's new, it's not incorporated in provincial programs. It is considered Schedule 1. So you do need a prescription needed to provide this vaccine. I do want to note here that because of how new it is, NACI has not yet included Prevnar 20 in their pneumococcal pneumonia chapter since the last update was in 2018. However, for patients who are 18 plus who require pneumococcal pneumonia vaccine from the pharmacy, they should be receiving Prevnar 20. And I know many of you have noticed that you have not been able to order Prevnar 13 anyway, as it's being phased out. I do want to make a note here that even though NACI has not provided recommendations on Prevnar 20, the CDC 2022 recommendations in the United States have included Prevnar 20, where they recommend routine administration with Prevnar 20 without the need for Pneumovax 23 after for adults 65 and adults 19 plus with comorbidities and risk factors. So the overall message is to carry on with vaccinating and recommending patients who you previously recommended Prevnar 13 to, now to get Prevnar 20, since with the additional 7 strains, it covers the majority of serotypes that cause pneumococcal pneumonia in Canada. And on the left bottom hand side of the screen, I've just included a little bit of information on the burden of disease for patients 50 plus to show that definitely we always think 65 plus with pneumococcal pneumonia. We do want to think 50 plus because of the high burden of disease, especially if they have comorbidities. I also want to do an update on Shingrix. So I'm sure most are aware over a year ago, Shingrix was updated to Schedule 2, so non-prescription status. We do know that we want to recommend it for all patients age 50 plus. However, the newest update to the indication is for immunocompromised patients age 18 plus, and this is immunocompromised patients due to medical condition or therapy, or patients about to be immunocompromised due to medical condition or therapy. And I know, we've had a lot of conversations about this new indication, and as pharmacists, it can be really challenging to identify who is immunocompromised. We've seen it with the COVID vaccines, how it's a little bit challenging. So we're really excited to kind of bring out this new tool that we've developed that is an algorithm, a tool, a decision-making tool to help pharmacists make a decision on identifying patients who are 18 to 49 who may benefit from Shingrix. So I'll be sending out the tool with the presentation slides. It highlights conditions like cancer, transplant, HIV, which have a lot of evidence to support its use, and other considerations around medications and immunocompromising states. And this was developed looking at the evidence submitted to Health Canada to expand the indication, Also looking at various product monographs for immunocompromising medications, taking a look at expert opinion, as well as guidance from the CDC, as NACI does not yet have an updated chapter including this indication. I won't be going over the tool step by step here, but you'll get it as a part of the PDF that you get after the presentation. Okay, so just a couple of quick comments on implementation. So in the pharmacy, what are the opportunities for pharmacists and pharmacy teams, the who, the when, and the how? So in terms of who we should be making recommendations to, again, we know we could potentially have a heavy flu season ahead of us. We want to make recommendations for flu for everyone 6 months and up. And you can refer to the previous slide on the preferred products for those patients. Again, for ages 50 to 64, you may want to consider a Sympemtech if the patient is willing to pay or if they have coverage for vaccines. Additionally, for patients 50 and up, we want to get them vaccinated and protected against Shingrix and Prevnar. We want to get their lungs protected, especially with flu and COVID. And for younger adults, which we didn't mention in this presentation, but I would like to just mention it here to not forget meningitis B for patients who are 10 to 25, as meningitis B is never included in provincial programs, so your patients wouldn't have gotten this vaccine, and HPV for patients 9 to 45. Just a quick note that Gardasil 9 recently got an expanded indication for head and neck cancers for people of all ages, sorry, not all ages, people of all genders between 9 to 45 years old. When to make these recommendations, so you can do it with passive screening. So when they're booking, if you're using a booking site or a booking link, your Facebook page or anything like that, you can include details on that and how to and have patients self-identify during that time. You can include posters or brochures when in waiting areas that they can take a look at. In the pharmacy, you can make these recommendations when you're actually vaccinating, so reviewing their vaccine history and discussing with them at that point. And how to make these recommendations, we already discussed posters, pamphlets, using various materials, using technology where possible, so booking systems, pop-ups, and reminders for patients to have them help you identify themselves for this. A quick overview of the immunization workflow as well. So when the flu appointment is booked, try to incorporate screening for other vaccines where possible, if digital, providing educational resources or links to help patients self-identify. When the patient arrives for the appointment, check the profile for vaccine history, making sure that you make a strong recommendation for any missing vaccines. During the waiting period before the vaccines, displaying educational material in the waiting area. When you're giving the vaccines, addressing their questions, if there's any hesitancy there, you can provide their recommendations at that point too for other vaccines. And during the observation period, they have to wait in the pharmacy, supplying vaccine, hand out information for any recommended vaccines that they didn't receive today, and booking up a follow-up appointment to get those missing vaccines.
So I just wanted to make everyone aware that we do have an additional webinar that you could watch if you have another hour to spend. Many of our pharmacies are engaged in pediatric vaccinations. And last winter, we implemented CARD into 5 of our whole health locations. And we collected surveys from children and from parents and from pharmacy staff, immunizers, on how that went. And CARD, it's a framework to improve pediatric vaccination experiences. And we were able to implement that into our pharmacies quite well. So if you have an hour, please move over to the OPA webinars and watch that through with myself and Dr. Taddeo. We did find in our study that children reported a reduction of pain and a reduction in fear when we implemented CARD. And parents said that CARD helped them a lot. And pharmacists had very positive views on CARD. And they made a number of small changes to their usual practices that meant a lot for children.
We have a couple of FAQ questions that we've put together, some of which we've already answered, so we won't read each one. As we've reached the 8 o'clock timeframe, we'll go back to questions now, and if anybody wants to stay after, we'll just leave these on the slides here if you want to read them.
Yeah, so there's quite a few questions came in, Molly, and a lot of them are about pneumonia and shingles. So it makes me think we need to do another webinar just on those topics. But the first one there is for COVID shots, is 2 doses still considered a primary series before they can do a bivalent as a booster?
Yeah, good question. So for general patients, the primary series is 2 doses. If you have immunocompromised patients, the primary series is 3 doses. So it depends, but for most patients, it is still the 2 doses that they need to receive.
Yeah, and there might be a patient who got Johnson & Johnson where that's a 1 dose primary series, if you counter that. So the next question is Prevnar 20. Are there problems to have Pneumovax after, or only no need, and why? So
good
what
question,
to do after Prevnar 20?
So because Prevnar 20 contains the 20 serotypes there, and it's a conjugate vaccine, which compared to a polysaccharide vaccine like Pneumovax, conjugate vaccines have produce a stronger immune memory. They're better vaccines. And so there's no need to give Pneumovax after. It's not really recommended by any of the guidelines to give Pneumovax after as well. So for patients, if they get Prevnar 20, at least by the CDC, we're still waiting on NACI guidelines, but I think it might be similar. If they got Prevnar 20, that's the only pneumococcal vaccine that they need. Makes things a bit easier.
Yeah, and the other question is similar topic. If a patient had Pneumovax, should they also wait 1 year before Prevnar 20? And can you clarify so they don't misunderstand, Pneumovax is no longer recommended 8 weeks after Prevnar 20. So maybe just reinforce that.
Yeah, so if the patient got Prevnar 13 in the past, they can get Pneumovax 23 as a follow-up, but with Prevnar 20 now, because of the strains included, we don't need Pneumovax anymore. So it's just Prevnar 20, at least until we find out something else from NACI through their new update. What was the first part of the question for agents?
So it was, where did it go? So if a patient had Pneumovax, should they also wait a year before Prevnar 20?
Okay, good question. So within the CDC guidelines too, if they had Pneumovax, they are recommending a year after that to get Prevnar 20.
So the next 2 questions are about shingles. So if a patient suffered a lot from shingles and they're only 23, but the doctor is recommending to give Shingrix now, is that okay?
Yeah, really good question, because technically it would be off-label use if they're not immunocompromised, but is there a reason why they have had so many recurrences of shingles? That might be a conversation that you have with the physician to decide that together.
So what if a patient never had a documented case of chickenpox? Do we still need to give them Shingrix?
So really, really good question too. We actually address this in the algorithm that you'll receive. So basically patients who are age 50 plus, regardless if it's documented or not, we assume that they previously had chickenpox. If they're under 50 and they have no documented history of chickenpox, then you would want to give them the chickenpox vaccine, right? Farivax, which is a live vaccine. So it depends. There might be some contraindications to that. But essentially, like if they didn't have chickenpox before, shingles is the reactivation of the chickenpox virus, right? So getting the shingles vaccine does not prevent you from getting chickenpox, and it won't do anything if you never had chickenpox. So if they never had chickenpox and they're under 50, you may consider Farivax for them.
There's a lot of interest here in the Prevnar 20, Molly. So are pharmacists authorized to administer Prevnar 20 if NACI's not yet put out a statement about it?
Yeah, so great question there. Pharmacists, it is a Schedule 1 vaccine. We do have the scope for, because it's not included in the provincial programs, we need to get a direct order and a prescription for it. The issue is right now we cannot access Prevnar 13, right? And we need to vaccinate these patients against pneumococcal pneumonia. NACI is what they do is they provide guidance to inform provincial programs on how to run their provincial programs. So a lot of their recommendations are population-based instead of individual-based. It is best practice in this situation, right? As pharmacists, for us to make a decision on with the available pneumococcal vaccine, which is Prevnar 20. It's basically the same as Prevnar 13 with those additional 7 strains. If we get that prescription, we should administer it.
So 2 similar questions about the Prevnar 20. So the first one is, if a patient got Prevnar 13 in the past, how long do they have to wait to get Prevnar 20? If they got Prevnar 13 and Pneumovax already, is there any advantage to Prevnar 20? And the other one is, if they had Prevnar 13, is Prevnar 20 recommended?
Yeah, good question. The short answer to that question is that we don't know, right? We don't have a lot of evidence on intervals between previous pneumococcal, a full pneumococcal series, and then adding on Prevnar 20 after that. There was one study that was done that looked at Prevnar 20 after either a Prevnar 13 or after a Pneumovax 23, and then also after a Prevnar 13 plus Pneumovax 23. The intervals that they used in that study were about 1 year or so after their last Pneumovax dose. And so, you know, I think there's definitely a benefit to patients who have received Prevnar 13 plus Pneumovax 23 to eventually get Prevnar 20, because again, with the conjugate vaccine, with those additional 7 strains, you're getting that long-term immune memory as opposed to Pneumovax 23. So that's something that potentially NACI might give us a little bit more guidance on. Yeah.
Okay, so stay tuned for more. And looks like maybe the last question. So it's about mixing Moderna to Pfizer for the 6-month and up group. So I'm guessing starting a series with one and switching to the next. Have we seen any recommendations there?
I can't recall off the top of my head if there's a specific recommendation for that age group, but I assume it's similar to the other age groups. And I would encourage you to look at the recommendations per province, where if both vaccines are indicated, then you can finish the series with whichever one's available at that time.
Yeah, I also haven't seen anything that says it's contraindicated to mix in that age group. But yeah, to look it up, it's probably better.
So is that it for the slides then, Molly? We made it to the end.
Yes, we have made it to the end. Thanks so much, everyone, for going on this journey with us so far. And we really thank you for your time. If you have any questions, my contact information, my email is on the slide here. You'll also be receiving an email from me likely tomorrow or a couple days later with the recording and the slides. So yeah, otherwise, have a great evening and best of luck for this flu season.
Yeah, so just to address the question there, yes, the recording will be emailed out to all the registrants. It's also will be on Whole Health's YouTube. It will be on our Facebook page as well. So you can find it on any of those platforms to review at a later date. Thank you, Molly. Thank you, Rangyang. I certainly learned a lot myself. That was a really informative and practical session. So thank you very much.
Thanks so much. Great job.
Thanks everyone for attending. Yeah. Thanks, Molly. Thanks, James.
Thanks, James. All right.
Good night.
Good night.
Good night.